All right, everyone. So today's topic is going to be pulmonary neoplasms, also known as lung cancer. It's not the funnest topic to go through, but we will try to get through it. And when we talk about cancer, we talk about it from the perspective of the primary care physician assistant. And so we're not going to get caught in the weeds and caught up in all the little details of exactly which chemos, which radiations. That we're going to try to look at it from the perspective of recognizing commonalities and just being able to diagnose and knowing when to refer for different types of masses within the lungs and then different types of cancers. Here's our instructional objectives. There are quite a few. Most of them are pretty superficial type instructional objectives, so kind of listing things, summarizing things, so that you don't get caught up in trying to memorize a lot of details that won't be of much use to you as a primary care PA. So when we talk about lung cancer, I'm sure everyone can recognize at least one of the people on this slide that I have for you here. We have Peter Jennings, famous news anchor. We have Claude Monet, famous artist. Christopher Reeve's wife, Dana Reeve, Walt Disney, Paul Newman, and George Harrison. And there's probably many, many more that could fill up the slide, because lung cancer is a very prominent cancer because of smoking, majority of the time. It is the leading cause of cancer deaths. Remember that I'm talking about just cancer deaths here. It's the leading cause of cancer deaths in both men and women. About 22% of all cancer death is caused by lung cancer. When we talk about most common cancers, not most common cancer deaths, the most common cancer overall is going to be skin cancer because it occurs in both men and women. The most common cause of cancer in men is going to be prostate, and the most common cause of cancer in women is going to be breast cancer. But when we're talking about cancer deaths, it's lung cancer. Okay? And when we talk about lung cancer, 80 to 90% of cases of lung cancer are a direct result of cigarette smoking. And really, the correlation between cigarette smoking and lung cancer, it's synchronous. So the more you smoke cigarettes, the longer you smoked, and the more cigarettes you smoked, the higher risk you have of developing lung cancer. We usually don't see lung cancer under the age of 40. It's usually kind of the median age is around 70. So increased age, increased smoking history, increased incidence of lung cancer. And it's not a good cancer to have. Not that any cancer is a good cancer to have, but lung cancer really has a poor prognosis overall. According to some statistics here, a relative 5-year survival rate, which is usually what we look at when we look at cancer. We look at, how many folks with cancer, with this specific type of cancer, live to 5 years. For kind of a combined total for all types of lung cancer, we have about 21% of patients that reach 5-year survival. But as we see, especially patients with small cell lung cancer, 85% of these patients die within 2 years, so it has a pretty dismal prognosis. And we'll go into kind of the different types of lung cancer and what we can do to try to prevent it, and how to recognize it, what the different associated symptoms are with it, and otherwise. So the lecture outline for today, we have really two main categories. Primary lung cancer, which is lung cancer that starts in the lung, and then we also have secondary lung cancer, which is kind of aka metastases to the lung. And actually, secondary lung cancer is more common than primary lung cancer because all of the blood in the body goes through the lungs, right, to get oxygenated. And so different types of cancers from other places like the breast, colon, the kidney, travel to the lung as metastases. And so we sometimes can see patients with either symptoms or masses within the lungs, and that's secondary lung cancer. We're really not going to focus on secondary lung cancer for this lecture. We're primarily going to focus on primary lung cancer. And within that primary lung cancer category, we have bronchogenic carcinoma, which is kind of another word for just lung cancer in general, primary lung cancer. And within that bronchogenic carcinoma, we have small cell lung cancer and non-small cell lung cancer. And I think we have these mixed up. I think it's actually 15% for small cell and 85% for non-small cell. Sorry about that. When we look at non-small cell cancer, there are 3 subcategories for non-small cell. Going to be adenocarcinoma, which is the most common lung cancer of all types. We have also squamous cell and large cell, which tends to be the least common of the primary lung cancers. We also have kind of lumped into the pulmonary neoplasm lecture mesothelioma, lung nodules, solitary lung nodules, and pulmonary carcinoid. So we're going to go through these one by one. When we talk about bronchogenic carcinoma, we said before there are 2 subgroups. We have small cell lung cancer, which is just really small cell lung cancer, and then we have non-small cell, which are combined squamous cell, adenocarcinoma, which is the most common, large cell carcinoma. And then we also have another really rare type we don't really tend to talk about very much. It's pretty important to differentiate between small cell and non-small cell lung cancer because, one, small cell lung cancer is way more aggressive and tends to metastasize early. So we have to recognize it as soon as possible. And the surgery is not generally an option for small cell lung cancer, whereas for non-small cell lung cancers, if you catch them early enough, surgery can be an option for these types. So it's important to try to differentiate the difference. Not always can we do that just with imaging, but we can also get things like biopsies or samples of the fluid or the mass around it, and we can make that diagnosis that way. So they're pretty different small cell and non-small cell, and we're going to go into the specifics of this, but generally speaking, small cell lung cancer is prone to spreading early, so we get metastasis early. It usually can't be surgically resected, and it has an aggressive course. So it says here the median survival untreated 6 to 18 weeks, which is pretty quick. Whereas small cell lung cancer tends to spread more slowly, not necessarily, but in most cases it does. It can be cured in the early stages by resecting it, and chemo and radiation are used in advanced disease. We also use chemoradiation in small cell lung cancer, but a lot of times by the time it presents, we're mainly using more palliative care type treatments for small cell lung cancer. Like we said at the beginning of the lecture, cigarette smoke is the main culprit, the main risk factor behind lung cancer. 85 to 90% of cases of lung cancer are the direct result of cigarette smoking. And like I mentioned at the beginning, there's a linear relationship between the pack years of smoking and the risk of lung cancer. So the more you smoke, the higher the risk you have of lung cancer. As far as adenocarcinoma is concerned, though, it is the cancer that is least associated with smoking. In other words, there are several cases, and especially women, that tend to get adenocarcinoma that don't smoke. Dana Reeve is one of those women that developed adenocarcinoma and never smoked. So that's one kind of exception. But still, even though adenocarcinoma has the lowest association with smoking, smoking is still the greatest risk factor for adenocarcinoma. There is some incidence of lung cancer from secondhand smoke exposure, but it is a lot lower than cigarette smoking or primary smoking. Asbestos tends to cause mesothelioma, although it doesn't cause bronchogenic carcinoma. But when you put smoking and asbestos together, the combination has a synergistic increase in the risk of lung cancer, so bronchogenic carcinoma, which we'll talk about a little more in depth as we move on. Other risk factors which are less common are going to be radon, which we don't have basements down here, but up north they have more basements, and radon tends to be found in basements, so that's a risk factor for lung cancer. And then COPD is also can be a risk factor, but it's really more the smoking. But there is some independent risk factor associated with COPD aside from smoking. This is more a patient encounter thing, but determining the pack year is important for for understanding how long or how much of a risk a patient has. To calculate the smoking in pack years, you're going to divide the number of cigarettes smoked per day, which is 20, right? Or divided by the number of cigarettes in the pack, which is usually 20. And then you multiply by the number of years that they've smoked. So however many cigarettes they smoke in a day divided by the number of cigarettes in a typical pack, which is 20, and you multiply that by the years smoked. So for an example, if you smoke 70 cigarettes a day, which probably super expensive, probably broke, you divide that by 20 cigarettes in a pack, that is 10 times 10 years, that's 35 pack years. So this is important. You definitely always want to calculate this and ask your patients when you're talking about patients that you think could potentially have risk factors for cancer, for lung cancer. So clinical findings of lung cancer. There's really two ways that we find lung cancer. One is the symptomatic presentation. So usually by the time a patient is symptomatic, you can make the diagnosis of lung cancer in 75% of the patients. The other way that patients kind of come across is incidental findings on imaging. So let's say they have a little cold and they go in and you do a chest x-ray and you see a lesion on the chest x-ray that's not infectious, then you might investigate a little bit further on that. Clinical presentation really depends on the type of cancer that they have, the location of the primary tumor, how far it's spread outside of from that primary tumor, metastases, and then the presence of other extrapulmonary symptoms such as paraneoplastic syndromes. Osmosis does a really good job of categorizing the different clinical findings in lung cancer. So I kind of took some of this from their presentation and the way that they organize it. But the way that I've come to organize my clinical findings in lung cancer is 5 different things that you look for. The first category of clinical findings is going to be the local symptoms, the things you think about that come from the lungs. So coughing, especially like a new or a change in a chronic cough, shortness of breath, dyspnea, coughing up blood, hemoptysis, chest pain, and recurrent pneumonias. These are termed kind of a post-obstructive pneumonia. So you have an obstruction in one of the airways that's preventing airflow from there. You get kind of collapse of the distal portion of that part of the lung, and you get these recurrent pneumonias. So that should be kind of a trigger for you to think lung cancer. So those are the local symptoms. Then these patients also tend to have kind of more constitutional symptoms, more kind of general symptoms. And these symptoms tend to indicate more advanced disease. So we have anorexia, not really being hungry, not really wanting to eat too much, unintentional weight loss, generalized kind of unwell feeling, kind of just weak, not really having much energy. They can get fevers. They can also get some extrapulmonary manifestations, which I will show you in the coming slides. Paraneoplastic syndromes is the next category. It's a pretty large category, and I will go through these briefly in a slide coming up. Then we have these kind of extrapulmonary manifestations like local invasion. So as the tumor grows, depending on where it's located, it can kind of infringe or move onto other structures within the thorax and cause different types of presentations. So especially those lesions that are growing kind of in the apex of the lung, and in the middle of the, kind of towards the central portion of the lung, can kind of infringe on the superior vena cava as it dumps into the right atrium. And that can cause some symptoms. Usually the symptoms of severe vena cava syndrome are going to be engorgement of the vessels, the veins above, kind of in the chest, neck, face area. I think I have a slide on that, the next slide coming up. Other local invasions that can happen with the growth of lung tumors will be phrenic nerve paralysis. You can get recurrent laryngeal nerve issues where you get hoarseness. You can also get these tumors when they have tumors kind of up in the apex. They're called PANCE tumors. And these tumors they can infringe kind of on the brachial plexus as it's running out towards the arm. You can get arm pain and weakness. Also, if it's more centrally located, the PANCE tumor can actually kind of rub up against and kind of disturb the sympathetic chain. And when it does that, you get a syndrome called Horner syndrome, which is ptosis, meiosis, and anhidrosis on one side of the face. And I have another slide that will go over that. It can also invade the pleura, and you can get pleural effusions, like we talked about in the pleural effusion lecture. You can get little localized exudative pleural effusions from metastasis or from malignancy. Okay. And then the other symptoms that patients can present with later on in the disease process will be symptoms that you get from distant metastases. So the main places that lung cancer likes to go are the brain, the bone, the liver, adrenal glands. And depending on where the metastases are, you can get some other symptoms. For instance, if the tumors travel to the brain, you start getting lesions on the brain, you can get headaches and vomiting and the other types here that you can see. So those are kind of the 5 main categories of clinical findings in lung cancer. And we are going to go a little bit deeper for the paraneoplastic syndromes and some of these other syndromes that we see, because that's what's highly testable for your exam. So as I was mentioning, tumors that tend to be kind of in the mediastinum, kind of where the superior vena cava lives, can cause this engorgement of the vessels in the chest. You get kind of this varicosities in here where they get all swollen up. You can also get a really red face and kind of facial flushing and fullness and edema. These are most commonly seen with small cell lung cancers because, as we'll see, small cell lung cancers tend to be more centrally located. And here's a picture of the tumor infringing on the superior vena cava. Like we mentioned, PANCE tumors tend to be up in the apex, and they can disturb the brachial plexus. They can cause thoracic outlet syndrome. They can cause severe pain and weakness in the affected in the ipsilateral upper extremity, and they can also cause that Horner syndrome that we talked about. These tend to be more squamous cell carcinomas and adenocarcinomas. Other things that we mentioned before: phrenic nerve palsies, recurrent laryngeal nerve palsies, Horner syndrome, and then pleural effusions, like we mentioned before. Here's my favorite medcomic slide about Horner syndrome. It's meiosis, ptosis, and anhidrosis, which means you don't sweat. You have on one side of the face, the side that's affected, it affects the sympathetic chain. And so meiosis, you're going to have a constriction of the pupil. You're going to have ptosis or upper eyelid drooping, and anhidrosis is not going to sweat on that side of the face. And that's a sign. Usually PANCE tumors that cause, or apical tumors in the lung that disturb the sympathetic chain. We said before that the main places that the lung cancer likes to travel to are the hilar lymph nodes, the brain, bone, adrenal glands, and the liver. So there is a little mnemonic that you can use. Usually when people smoke, they have bad breath, so you can say HI, which is for hilar lymph nodes. Bad breath attacks liver, so bone, brain, adrenal glands, liver, and that's how you can remember where lung cancer likes to travel to when it metastasizes. So getting into paraneoplastic syndromes, a paraneoplastic syndrome is something that happens outside of the lungs and is caused by different different hormones and things that the tumors secrete that kind of mess with homeostasis otherwise in the body. So syndrome of inappropriate antidiuretic hormone is going to be where obviously diuretics help you get rid of water in the body. When you have syndrome of inappropriate antidiuretic hormone, that's you tend to hold on to water. When you hold on to water, the concentration of sodium within your vasculature goes down, and so you have all sorts of issues related to that. That's one of the paraneoplastic syndromes. We also have ectopic ACTH secretion that is mostly seen in small cell cancer. And essentially you get this ectopic adrenocorticotropic hormone, and that increases cortisol, so you get the same kind of symptoms you see in high cortisol levels, so Cushing's type stuff, so moon phases, central obesity, striations, and things like that. PTH-like hormone secretion, most commonly in squamous cell carcinoma. And what we see in that, we see increased parathyroid hormone that increases the calcium reabsorption and the increased calcium within the vessel. And so when we see that, we see hypercalcemia, and the symptoms that we see with hypercalcemia are going to be what we like to term stones, bones, groans, moans, psychic overtones, and thrones. And I'll go into those a little more in detail. So we say patients that have hypercalcemia, they have several different types of symptoms. Stones stands for kidney stones. Excess calcium equals excess kidney stones, so they get stones. Bones, you get a lot of increased parathyroid hormone, increases the reabsorption and the breakdown of bone to take away the calcium and put it into the vessels. And so with bones, you get pain, you get breakdown of the bone. Groans are this like kind of lethargy and fatigue that you get with hypercalcemia. Moans are the GI effects, so constipation, abdominal pain. Psychic overtones, patients tend to be a little confused. They also have some depression. And thrones stands for toilet, thrones. They tend to have lots of polyuria and polydipsia. So that is hypercalcemia that you get with the parathyroid-like hormone secretion, and like we said, most commonly seen in squamous cell carcinoma. Going on to the hypertrophic pulmonary osteoarthropathy, it's one that we don't see very often. I don't think I've ever seen it on a PANCE question, but you see it most often in adenocarcinoma and squamous cell carcinoma. Essentially, you get this severe long bone pain, and the classic triad of hypertrophic pulmonary osteoarthropathy is going to be clubbing of the fingers, periostosis, which is inflammation of the periosteum, and synovial effusion. So mainly long bone pain is what we see. Moving on, we have this Lambert-Eaton syndrome. Lambert-Eaton syndrome is this myasthenic type syndrome. It's kind of similar to myasthenia gravis that you might remember from your neuro module. But the difference is that as you use the muscles, with myasthenia gravis, it gets worse the more you use your muscles. But with Eaton-Lambert, you actually get better the more you use your muscles. And you get mainly proximal limb weakness, legs greater than arms, and it has to do with the presynaptic calcium channel blocking. I'm not going to go into too much of the pathophys of it, but eventually, as you're using your muscles, you build up enough calcium to have a normal contraction, so you get better with movement. Last on this long list of paraneoplastic syndromes is digital clubbing. I don't know that you really consider that a paraneoplastic syndrome, but you do get digital clubbing, and that can happen with any type of pulmonary condition, and I think we showed a picture of that in the intro lecture. So how do we put all those pieces together? That was a lot of information we just threw at you. This is my chart. I made it. I took it kind of from Paul Bolin and some osmosis, and try to put all the pieces together so that I can look at one chart that kind of sums up all of what we just talked about. So we'll go through it. Lung cancer. Bronchogenic carcinoma essentially is what we're looking at. We have those that are centrally located and those that are peripherally located. And when we're saying centrally located, we mean closer to the mediastinum, right? So closer to the heart. Peripheral means kind of more out in the lungs, more out towards the periphery. Okay, so the two that tend to be centrally located are small cell lung cancer. They start with an S, so small cell lung cancer centrally located, and squamous cell lung cancer, which also starts with an S. So squamous, central, small lung cell cancer, central. Okay. Then when we look more peripheral, the two that tend to be more peripheral, adenocarcinoma for sure. Large cell lung cancer can be more peripheral than it is central, but it can kind of be anywhere. Large cell lung cancer kind of doesn't follow the rules. You can see that the boxes are color coded. So we have a green box all the way to the left. That's going to be our one and only small cell lung cancer. All these other three are categorized as non-small cell lung cancers. So squamous, adeno, and large cell. Okay, so let's look at the small cell lung cancer. We already know it's rapidly progressive. It's the worst kind of lung cancer to have. There's a strong correlation to smoking. It tends to metastasize early. And then because it's centrally located, we get the SVC syndrome. And we also get the paraneoplastic syndromes, Lambert-Eaton, the myasthenic type syndrome. You get SIADH and ectopic ACTH. And because it's centrally located, it's hard to get to and so rapidly growing, we don't use surgery for small cell lung cancer. We treat with chemo plus or minus radiation. Okay, that's for small cell. Moving on to squamous cell. I feel like squamous cell has the most different things associated with it. We said that it also has a really strong correlation to smoking. And squamous cell lung cancer can cause these cavitation type lesions where you get these cavities that form in the lungs. And it's the most likely of all the cancers to have these cavitations. I kind of think of squamous, the QU kind of makes this k sound. So cavitation, squamous. I don't know, maybe that's a stretch, but that's how I remember it. It doesn't tend to metastasize early like small cell does. It can take a while before it does metastasize. And these, because they're centrally located, they also have the PANCE type tumors that are associated with Horner syndrome. And these squamous cell ones are the ones that really do have the paraneoplastic syndrome of PTH resembling peptide. So the ones that you get those hypercalcemic states in. For treatment of squamous cell, it can be surgically resected if we can catch it early enough. Although it's centrally located, it can be kind of tricky, but otherwise chemo and radiation, the treatment. Looking at the two peripheral ones, adenocarcinoma, like we said before, is the most common type of lung cancer that we have. And it's more common in smokers than non-smokers, but it's the most common type of cancer you can get if you're a non-smoker. Okay. Also, it's more common in women than any other type of lung cancer. Adenocarcinomas can have pleural effusions. They tend to be slower in progression, but they do have some early metastasis, which makes them deadly. The treatment depends on the staging. So there's a combination of surgery, radiation, chemo, and I wouldn't really expect you to be at the level of having to make that determination. If you can find it early, because it's peripherally located, you can take a lobe of the lung out and still be fine if you can catch it before it metastasizes. You can also get some PANCE tumors if it's in the apex, and Horner syndrome tends to go along with PANCE. Last but not least, we get large cell lung cancer, which really doesn't follow the rules too much. It kind of does what it wants. It's usually peripheral, but it can be anywhere. It can occasionally have some cavitation, maybe yes, maybe no. It doesn't metastasize too early, and you treat it kind of similar to the way that you treat adenocarcinoma, since it is peripheral as well. So that's kind of the nutshell of what we just talked about. They love to ask on PANCE questions about paraneoplastic syndromes, so really take the time to understand the patho behind them, at least the basics. And then remember which syndromes happen with which types of cancer. If you put the pieces together, they'll tell you they have a centrally located lesion, they have a PANCE tumor with Horner syndrome, and you put all those pieces together, you should know, okay, that sounds like squamous cell lung cancer, or that sounds like this type. And so that's how I want you to approach learning these types of cancers. I know some of you guys are all about Picmonic. I'm not a real huge fan, but there's a picture here that kind of mimics the chart that I just showed you. This is the Picmonic version, has some little tips and tricks trying to help you remember which of those paraneoplastic syndromes and extrapulmonary findings are associated with each of the different types of bronchogenic carcinomas. All right, so how do we diagnose lung cancer? Like I mentioned before, either patients are coming in symptomatic and we diagnose lung cancer with imaging, or they come in asymptomatic and we accidentally find the lesion, a pulmonary nodule, and then we monitor it, or we do more to it, we biopsy it, or whatever we need to do. So, nearly all patients with lung cancer will have abnormal findings on the chest radiograph or CT scan. Chest x-ray is really what we do first. It is the most important radiologic study for diagnosis, so that's usually where we will see the mass initially, but it's not used as screening because it's just not good enough to see all different types of little masses that we're looking for. Almost always you will see abnormal findings on a chest x-ray with someone with lung cancer though. CT with scan of the chest with IV contrast is useful for staging. It also can tell you the extent of local and distant metastasis. It can tell you whether you have lymphadenopathy associated with it, especially in the mediastinum. And here you see a chest x-ray, and up here you can see there's definitely something here. But in some cases, especially with non-small cell lung cancers, you can have trouble differentiating this between a mass and like a pneumonia or an infection, a localized infection. And so a lot of times we'll use CT to help us differentiate whether it is a mass or an infiltrate. What else do we do besides imaging? Well, once we know that we have a mass somewhere, we got to figure out what type of cancer it is so that we can give the patient a prognosis, we can stage it, and we can decide what the best treatment is for it. So there's several different ways that we can determine the type of cancer it is. And really what it comes down to is, where is the lesion? If it's centrally located and close to the airways, we can do bronchoscopy, where we go down with the scope and we can take a sample of the tumor that way. If it's more peripherally located, we can't really get to it with a scope. So those are the type that we have to do, usually like a transthoracic CT guided biopsy or fluoroscopy guided biopsy, where we go in through the thorax with a needle, sometimes even with the VATS like we talked about before, where you go in with cameras to try to take out a piece of this tissue so that we can stage it or diagnose it and stage it. Other ways we can do it, we can look at the patient's sputum if we can get it, but it's not very good at diagnosing peripheral lesions. We can also do a thoracentesis, so if a patient has a pretty large pleural effusion, we can take some of that fluid and run analysis on it to see what type of cells are present. And then at worst comes to worst, we can't really figure out what's going on. We can also use a PET scan, helps us give us information if the tumor is primary or secondary, and whether or not there's lymph nodes associated and metastasis. As far as for the test, it's kind of hard to know what the best thing is for which situation. I highly doubt they will ask you that on your PANCE, and so I would keep it very simple if I were to ask you something like this on my exam. Same thing goes when we stage. So you should know that the staging between non-small cell and small cell lung cancer is very, very different. For the non-small cell, we use the TNM system. So the T stands for tumor. It has to do with the size of the tumor and the involvement with the structures around the area. The N is whether or not lymph nodes are involved and whether they're on the same side of the tumor or on the opposite side. And lastly, the M stands for metastasis and talks about the distant metastasis, whether it's in one place, more than one place, or if it has not metastasized. And that helps once you stage it, you can give the patient a prognosis and you can come up with the treatment. Secondly, small cell lung cancer, as we said, it's really aggressive. And so it is harder to categorize with the TNM system. Some physicians still recommend using TNM, but generally speaking, we use the veterans staging classification, which essentially makes it pretty easy for us. It's either limited or it's extensive. And Obviously, if you have extensive disease, the prognosis is very poor. Accurate staging is super important. It gives the clinician information to guide treatment. It provides the patient with accurate information so they know, am I going to die tomorrow? I got to go get my bucket list taken care of, or do I have some time? What are my options? What am I looking at? And then also it kind of standardizes criteria for trials and things when we're trying new treatments to interpret the results. So how do we treat small cell lung cancer? Like we said before, the median survival for small cell lung cancer, it's not very good. So when you have that limited disease, the mean 2-year survival is 20 to 40%. The median survival is 15 to 20 months. If you have this 70% extensive disease, then your median survival at 2-year survival is 5%. It's really low. So you have usually less than a year or so to live. If you do have that limited disease, it's usually a combination of chemo and radiation. If the extensive disease, usually you start with chemo, and if they're responsive, then you can start using some radiation. But most of the time, by the time it reaches extensive disease, the majority of what you're using is more palliative type care. And that's a decision that's usually made between the oncologist and the patient. Surgery, like we mentioned before, you should not associate surgery with small cell lung cancer. It's not done. Non-small cell lung cancer, initial approach is, you got to ask 2 questions, okay? Is complete surgical resection feasible? Like, can we reach this tumor? Can we take it out? Is it somewhere where we can get to it? If it's yes, and the patient can tolerate the surgery, then we go for surgery. Surgery is the best option. It's the best thing we have to ensure that the patient survives, okay? If we can take out the whole mass, if it hasn't metastasized and there's not a lot of nodes or anything, then if we can take out that mass or that lobe, and then the patient can, survive, Like we said, patients with metastatic disease outside the chest are not candidates for surgery. And then even if you remove the surgery, if you just leave one tiny little microscopic cell in there, the chance of recurrence is still there even after you take everything out. In addition to surgery, we use radiation and chemotherapy. I don't think that neither on the PANCE nor on my test am I going to be so specific to ask you, what type of chemotherapy, what are you doing, what type of radiation. It's just too specific. So one of the reasons why lung cancer is the deadliest cancer that we have is because it's really hard to screen for lung cancer. When we think about breast cancer, we have mammography, we have ultrasounds, and we have breast exams, so we can kind of check ourselves. And also like colonoscopies we have for colon cancer, so we have some screening guidelines for that. For lung cancer, we really don't have good screening guidelines. We do have guidelines, but it's a lot harder to screen for lung cancer than for other things. So what's the recommendations for lung cancer screening? In 2021, the U.S. Preventative Services Task Force, or the USPSTF, recommends an annual low-dose CT for smokers aged 50 to 80. It says 55 to 80 here, but it's actually 50 to 80 that have at least 20 greater than or equal to 20 pack year smoking history, who either currently smoke or have quit smoking within the last 15 years. So that is the recommendation by the USPSTF. Once you reach the age of 80 or you quit smoking for greater than 15 years, then you can stop screening. And that's essentially because if you reach the age of 80, it's probably something else that will, I guess, cause death before cancer would. Another thing is if a patient has other medical conditions that are going to limit life expectancy, then we don't continue screening with the CT scans. Here's kind of a sum up slide. I had some sum up slides before, but this is another one if you want to take a look at it. So that was bronchogenic carcinoma in a nutshell. It's quite a bit, 40 minutes worth of talking about it, but we're going to move on from it. The next thing we're going to talk about very briefly, because we mentioned it again when we talk about restrictive lung disease and occupational lung hazards, is mesothelioma. I'm sure sitting at home watching a show, Jerry Springer, whatever you're watching at home, they always have these advertisements for mesothelioma and asbestos exposure. And what we see with mesothelioma is that it's usually, most cases are secondary to asbestos exposure. So we see patients that worked in construction, shipyard, shipbuilding, they're exposed, and usually the exposure has happened kind of in the remote past 20 years or more ago. 3/4 of these are pleural mesothelioma, so they happen in the lungs, and the other, and those are usually malignant. Then we have another 4th that are more localized, and those are more benign. We can see mesotheliomas tend to happen in the lungs and in the abdomen, and men outnumber women by far 3-1. Generally speaking, clinical findings: unilateral non-pleuritic chest pain, dyspnea, weight loss, cough. They can have these bloody pleural effusions, pleural thickening on chest x-ray. And if you do pleural fluid assessment, you'll see malignant cells. Tissue biopsies can also show that. It's not a good type of cancer to have. Again, the 5-year survival is about 5 to 10%. Cigarette smoke does not cause mesothelioma, but if you have mesothelioma and you are a smoker, your risk of having bronchogenic carcinoma goes way up. They're synergistic, so it's like 1 + 1 = 3 when it comes to your risk for having bronchogenic carcinoma when you have mesothelioma and you smoke cigarettes. Chemotherapy is usually what we use. If we have localized cases, we can also use surgery. So that's about the extent. We'll talk about that for this lecture, but we will mention it again later on. The last kind of category we're going to talk about that they love to test on is what we call a solitary pulmonary nodule. And this is the type of cancer that we tend to see when we kind of accidentally find it. We see these coin lesions or these solitary little masses or nodules on imaging. And usually they're less than 3 centimeters. They're isolated, they're rounded, and we see them on chest imaging, usually chest x-ray, sometimes CT. And this is surrounded by normal lungs, no infiltrates, no atelectasis, and no adenopathy. So it's just a lesion. We don't know why it's there. We don't know what it is, but it's there. We notice it. So what do we consider? Well, one, is the lesion malignant or benign? That's pretty important to know, right? Because the treatment's going to be completely different. And does it require some sort of biopsy or resection? Most of these lesions are asymptomatic, meaning that we see them kind of incidentally when we do chest x-rays or CT scans. The differential diagnosis for something like this, it's not all solitary pulmonary nodules are cancer. Differential diagnosis can be infectious granulomas, can be TB, bronchogenic carcinoma, a hamartoma, or a bronchial adenoma. Okay. Essentially what we have to do is we got to investigate. We got to figure out whether there's a risk of malignancy, because if we can catch these things early, we might be able to cure them, right? So that's kind of the goal when we see these solitary pulmonary nodules. Symptoms alone rarely establish the cause. You got to do more than just symptoms. But as we see, clinical findings and imaging data can help assess the probability of malignancy. So I'm not going to go and take out every pulmonary nodule that we find. We have to know, is this something that we need to take out, or is it benign? So there are things that tend to put you at a higher risk for malignancy, which are age. So older you are, the more risk you have. Rarely do we see malignant nodules less than the age of 30, usually above 30, and increasing with age, you have an increased likelihood of malignancy. Smoking, obviously, we've talked about smoking a whole lot today. If you're still a smoker after today's lecture, you did not listen well. But the likelihood of malignancy goes up with the number of cigarettes that you smoke. And then if you have a history of malignancy somewhere else, obviously the likelihood is going to be higher that your nodule is also malignant. Here's kind of a chart that kind of summarizes some of those findings and a few more. The size of the nodule and the way that it presents is also a determining factor. If, let's say you had a chest x-ray 2 years ago and they saw something there, and 2 years later we do another chest x-ray for something else and we see the same nodule and it hasn't grown, chances are it's benign. The way that the nodule looks on CT or on imaging. And nowadays we have calculators that you can download on your phone that you plug in all these kind of risk factors, and it calculates the risk of malignancy. So low probability nodules are going to require something different than high probability nodules. So here's an example of a calculator that was on Up to Date. You put in the age, whether they're male or female, history of cancer, emphysema, nodule size, and blah, blah, blah. You put all this in and it comes up with the odds of cancer. And so depending on where your probability is kind of depends on what you will do or how you will monitor how aggressive you're going to be with that. So this right here is kind of a simplified workup, okay? It can get a whole lot more complex, but for simplicity's sake, when you find the solitary pulmonary nodule, the first thing you want to do is look to see if you have a previous chest x-ray. It's going to provide a whole lot of information, because if you see a clear chest x-ray from, say, 6 months ago, and now you see this large nodule here, that's pretty rapidly growing. That's not a good indicator. So that's what the first thing you want to do. And they love to ask the question, what do you do? Well, first thing, you look for an old chest x-ray. If you can't find films and you don't know where, then you go proceed on with the CT, and you want to get the CT with thin sections through so that you can try to really differentiate. Radiologists are pretty good at being able to visualize certain characteristics of different benign versus malignant tumors. If you do get your hands on an old x-ray and you notice that this is a new nodule, you also proceed to doing CT. If you have an old chest x-ray and you notice that the nodule has not changed in size over 2 years, you can just follow this patient yearly. So you can see how the approach to it kind of differs with whether it's new, whether it's unchanged, or whether you don't know whether it's new or not. And then once you get kind of down here, this is actually really simplified. But there's a slide that I have next up that'll show you just exactly how complicated it can be. I don't expect you to get that complicated for the exam, but it's good to know that what you're learning here is kind of the basics. Like we mentioned before, the size of the nodule is important. The risk goes up with the increased size. So if you have a nodule that's less than 5 millimeters, really tiny, there's a 1% likelihood that that's malignant. But if you have one that's big, greater than 20 millimeters, you have greater than 50% likelihood that that's malignant. Here is that lovely algorithm that talks about the incidental solitary solid pulmonary nodule evaluation. It starts from finding it and then sends you down this long path of left versus right. And like I said before, I don't expect you to memorize this chart, but it makes sense if you follow it through. So I would recommend you kind of reading through it to kind of get a bird's eye view of what we do with these nodules. Here's an example of pulmonary nodule over here that's seen on a CT. And that's all we're talking about solitary pulmonary nodules. the last thing, well, second to last thing on here is carcinoid tumors. We're going to go this is like just brush the surface. Essentially, carcinoid tumors are these neuroendocrine tumors. They secrete hormones and things like that. And you can get them, generally you get them in the lungs and in the GI tract. And they're slow growing. They don't tend to metastasize often. They tend to present with the same kind of stuff that we see otherwise, hemoptysis, cough, wheezing, recurrent pneumonia, and they get this carcinoid syndrome, which refers to a group of symptoms caused by systemic release of different types of humoral factors, polypeptides, biogenic amines, and prostaglandins, and these are coming from the neuroendocrine tumors. This causes symptoms like flushing, diarrhea, wheezing, and hypotension. If we can, we surgically excise them, and the diagnosis is made usually by CT and then bronchoscopy. That's usually how we diagnose it. If they ask you a question on this, it's going to be a really kind of one-shot question, like maybe one random question on your test, and either you're going to know it or you're not. Usually they kind of pair it with this carcinoid syndrome that you see here. Last, but not least, is the secondary pulmonary neoplasm. We said we were not going to focus on that for this lecture, but essentially what this is cancer that comes from other parts of the body and metastasizes to the lungs. And so this results from spread. So we said that all the blood in the body gets cycled through the lungs so that it can be oxygenated. And so blood can get to the lungs pretty easily for metastasis. Usually the places that tend to metastasize there are, like we said before, kidney, breast, rectum, colon, cervix, malignant melanoma. And pulmonary metastases are common in patients with osteosarcomas as well. Usually how you see these patients present is they have nodules, masses, and usually more than one on chest radiography. And that's essentially what you need to know about secondary pulmonary neoplasm and what you need to know about lung cancer in general. So hopefully I gave you a good bird's eye view of what it looks like, how to recognize them, how to see these patients, how to work them up, at least initially, and when to refer them. Like I mentioned before, you don't really need to know too much detail about the treatment, more just kind of categories of treatment, and that's pretty much it. So thank you for listening, and I'll see you in class.